In this lecture, we will discuss ventricular escape rhythm, or idioventricular rhythm, including its origin, mechanism, EKG features, and potential causes. Ventricular escape rhythm, which is also referred to as idioventricular rhythm, occurs when a ventricular focus acts as the primary pacemaker of the heart. This rhythm can be found by itself or as a component of third-degree AV block or AV dissociation. So what you see here is that we have here our supraventricular pacemakers not firing. So here's our sinus node, and this is our AV node that have the X's through it, okay? And what's going on is because they're not firing, we get all the way down to our ventricles, and the ventricles end up setting the rate. So remember, there's those backup systems. So if our sinus node fails, maybe an atrial pacemaker will take over the rhythm of the heart, or the AV node. But if they both fail, the AV node also fails, and everything below it, we may get to the ventricles, where the ventricles now start becoming the pacemaker of the heart, okay? Now, ventricular escape rhythm may be isolated or a component of third-degree AV block or AV dissociation. Some causes include severe sinus bradycardia, sinus arrest, sinus node dysfunction, sinoatrial exit block, AV block with an inadequate junctional escape rhythm, hyperkalemia, and a consequence of some medications, such as in the setting of beta blocker, calcium channel blocker, or digoxin toxicity. Okay, so if you think about it, if we have a third degree or complete heart block that's blocking the AV node, okay, and sometimes we can get a junctional rhythm, meaning one that's coming from somewhere in our AV junction. However, if we're also not getting anything from that junctional area, maybe it's damaged, we may have a ventricular pacemaker take over the rhythm of the heart. So what can we see on the EKG? Well, in general, if you look at the EKG and you see a slow rhythm that has no identifiable P waves, as well as wide, bizarre QRS complexes, then you are likely dealing with a ventricular escape rhythm. The QRS interval is prolonged, reflecting the ventricular origin of each beat. This is because interventricular conduction is occurring outside the normal conduction system via cell-to-cell depolarization, which is a slower process and prolongs ventricular depolarization. So again, we're outside our conduction system, right, in our ventricles. So somewhere in our ventricles is taking over, and we have this place here. Let's just erase this so it's cleared. So we're starting from this area outside our conduction system, and we have this slow cell-to-cell depolarization that's depolarizing the ventricles all around outside our normal conduction system. So if things are slowed down, how does that appear on the EKG? Well, remember, going horizontally represents time. So if we prolong things, things will start to look widen, and we see that here. Our QRS complexes are widened throughout, okay, beyond our normal 70 to 110 milliseconds, okay? So prolonged QRS complexes, and we also said no P waves, okay? No identifiable P waves because we're not coming from the sinus node. It's all in this ventricles. Now, one thing to note is that it's possible to have retrograde capture of the atria, in which you may see P waves with an abnormal axis occurring after the QRS complex. And this is left often seen, but it is still possible, okay? So what we're saying is that you can actually have the P waves that travel retrogradely, okay, and if they make them up to the atria, you may see depolarization, and because of that, we may see a P wave that's retrograde and with an abnormal axis that's going in the other direction, and somewhere at the end of our QRS or in our ST or T wave segment area. Okay. Now, in addition, we mentioned that this idioventricular rhythm may be present in the setting of third-degree AV block or AV dissociation. And in such settings, it's possible to have an underlying sinus rhythm with P waves present. Okay, so again, what we're saying is maybe the issue is not with the sinus node, but the issue is only here at the AV node. So everything is blocked here, so nothing, the impulses are getting from our sinus node and depolarizing the atria, but they cannot get through our AV node. There's just a block there, okay? And because of that, we may also have a sinus rhythm that's going at its own rate, as well as a ventricular rhythm, okay? And in such cases, you may have what's called isorhythmic AV dissociation, in which the P waves and the QRS complexes are firing at the same place. And if you imagine this as a P wave, okay, these small P waves, you can see them appearing within there, okay? Now, that's not always the case, but that's one setting where we can see sinus P waves in the setting of complete AV block. Another thing to realize here is that this is a regular rhythm, meaning that the intervals between each complex are consistent throughout. So when we talk about our intervals, let's look at our R waves. So our waves here, okay, and we're saying that these intervals from each R wave will be the same, okay, in these ventricular rhythms. So we have a regular rhythm going on here. And lastly, if you recall, the normal intrinsic rate of the ventricular pacemaker cells in adults is generally less than 40 beats per minute, and often between 20 and 40 beats per minute. This corresponds to an interval of about 1.8 to 2.2 seconds between complexes, okay? So we're saying here is that our rate should be less than 40 beats per minute, okay? So how would we find a rate? Well, we're dealing with a regular rhythm, and because it's regular, we can count the number of thick lines, okay, or thick boxes, the bigger boxes, between each R wave, okay? So we'll go from this R wave to this one. So it would be 1, 2, 3, 4, 5, 6, 7, 8, 9, and then we do 300 divided by 9, which is about 33.3, okay? And obviously that's less than our 40 beats per minute, okay? So we have a regular rhythm with a wide complexes occurring at a rate of about 33 beats per minute, okay? And that sets us up for this idioventricular rhythm, okay? So hopefully this is not too difficult. Let's run through our chart here before we end. So our ventricular escape or idioventricular rhythm arises when these supraventricular pacemaker cells fail to fire. Okay, so everything above the ventricles is not working, so eventually the ventricles take over the rhythm of the heart. Okay, and that's where we get this ventricular rhythm that occurs at a rate less than 40 beats per minute. Okay, now this could be isolated or a component of complete or third degree AV block or AV dissociation. And some causes, we mentioned a bunch of them here, whether it has to do with the sinus node or the AV node, okay, or sometimes hyperkalemia can cause it, and some medications as well. We said the rhythm is regular, so our intervals between the R waves will be consistent throughout, with our rate will be less than 40 beats per minute. Often there's no P waves, okay, and because there's no P waves present, we also don't have this P to QRS ratio because we need a P wave to have that. Our PR interval, which also consists of a P wave, will not be present. Now there's some exceptions if we have retrograde conduction where it actually can go backwards in depolarized atria. In such cases, we can see those retrograde P waves with the abnormal P wave axis, and you may see that one-to-one relationship between them in a retrograde PR interval. Remember, one of the main things here is the QRS interval will be prolonged, okay? We're originating from somewhere within the ventricle. Because of that, we have this slow cell-to-cell depolarization outside our normal pathway, and because of that, we have these prolonged QRS complexes, okay, with those abnormal QRS morphology. There's going to be no grouping as well as no drop beats. Well, that's the end of this lecture. We discussed ventricular escape rhythm, or idioventricular rhythm, including its origin, mechanism, EKG features, and potential causes. I hope you learned something.